session today, next hour and a half, left atrial appendage closure, joined by an esteemed panel. Unfortunately, Devi couldn't make it. She got caught up in the whole fiasco of flight cancellations. So Ashish is going to be co-moderating this with me, and hopefully we'll do Devi's presence justice. I think without further ado, we'll get started with the first case, which I believe is Cliff. Take it away.
Well, good afternoon, everyone. On behalf of Harvard Medical School, Beth Israel Hospital in Boston, I want to thank the organizers for inviting me to come and present a case. Paul always asks me to present unusual left atrial appendage cases, so I'm going to talk about one that is not a nightmare, but brings up a lot of thoughtful notions concerning this, this technology. I have no disclosures relevant to this talk. So this is an 81-year-old with permanent atrial fibrillation. He's got a lot of comorbidities. He's had bypass surgery. He's got a AAA. He's got an EVAR. He's got renal cell cancer, for which he's had a nephrectomy, COPD, hypertension, diastolic heart failure. He's on apixaban 2.5 BID. He's got chronic anemia of unclear etiology, and he gets transfusions regularly. You can see his CHA2DS2-VASc score of 5 and his Has-Blood score of 4. So this is the angiogram of his appendage. I don't know if you can appreciate, it's not the best angiogram, but you can appreciate sort of a bilobed whale tail kind of configuration. And here's some of the preliminary echo images. You can see on the panel on the left, we have the 0 degree, 90, we've got the 45 degree and the 135 on the right panel. And here on the bottom right, you can see a 3D rendering of the morphology of this appendage, and I'm going to come back to that in just a couple minutes. And here's some of the baseline measurements. You can look at them yourself. I've kind of summarized them in the lower left corner. 0 degree was around 2 centimeters. You can see 0, 45, 90 degrees, about 2 to 2.5 centimeters, and 135 about 2.5, and depth is only about 11 millimeters. So based on those measurements, we decided to use a Amplatzer amulet device, and the size that was chosen was the one that you see circled here, the 28, and you can see the dimensions of that. And I'm only showing that to give you some idea of what these dimensions are. And looking on the left panel, you can see the device has been implanted, and you can see the angiogram of how it looks implanted. And then here's some of the echo images of the device as it sits implanted but still attached to the delivery system. And I don't know if you can appreciate, but there's a large unfilled gap. You can see it well on 3D in the bottom left image, and you can also see it in the other views as well. A sizable unfilled, uncovered lobe, if you will.
Before you go further, can we go back and actually poll the panel and maybe talk to some of the other operators that are here?
Am I allowed to go back?
Yeah, even before this. Just the measurements and the anatomy per se. Yeah, so these were the measurements, and I would basically start from Vivian and work our way this way as to A, what they think of the measurements, B, how many are using CT as a pre-plan as opposed to this, D, what do they think of the trabeculations, and D, what do they think of the depth?
It's a lot of stuff.
A lot of questions.
Did you remember all those?
Yeah, no. yeah. So you do.
Multiple choice questions. Multiple choice questions as opposed to multiple choice answers here. The anatomy is a little bit difficult. You can see on the 135 imaging that you have all those trabeculations, so your depth, is not going to be all the way to the tip of the appendage, but really just to the tips of those trabeculations. It also looks like there's some proximal trabeculations on that 135 view, so concern as to whether or not your device will fully cover that. As far as sizing, it doesn't look prohibitive. The depth is 11 millimeters, so maybe a little bit difficult for something like a Watchman if you're doing a 27, especially with the Watchman Flex with that distal end maybe not being able to fully expand because of those trabeculations.
So I would say maybe on the positive side, the measurements are appear a relatively circular orifice, which really always favored good sizing. And I would say the depth is 11. The minimum depth is 10 or 12 millimeters, depending on the size. And the pectinate muscle can lead to subselective.
I'll tell you that when I was looking at the depth, I was concerned that there wasn't a lot of depth there.
Yeah.
Even though the measurement there is 11,
Yeah.
I wasn't exactly convinced that there was 11 millimeters of usable depth.
Yeah. So it's going to be subselective.
And that was your reason to attempt the amulet. That was your reason
Yes,
to go with the amulet
exactly.
to begin with. Correct.
Yeah, I don't have a lot to add here, but you know, the big, just to reiterate the initial comments, I mean, my biggest concern is just the how big and prominent those pectinates are. So, I mean, part of it is they don't give you as much depth as you'd like, but the other consideration is that whatever device you decide to put in, it may get caught, right, on those pectinates. So it may be, and I suspect that maybe, although we'll learn more.
It's
in
going
the
to be
next few
something
slides.
else.
But okay, even better. But that will limit either a Watchman or the lobe of an amulet device. Those proximal pectinates can really keep you from fully expanding. Now, one's hope would be that the disc would kind of seal the deal, even if that's happening. However, if the lobe is so canted, that can be an issue. But we'll learn more.
Those are all real concerns that we had. Shall I move forward?
Please. Sorry to interrupt.
No, so we put in this 28 device, and I think you can appreciate a big leak posteriorly underneath the device. Can you all see that? So it's clearly not covering. So I will tell you that after seeing this, we put in a larger device, but it was impinging upon the pulmonary veins.
So Cliff, may I just add one more comment? There's the leak, but also one of the striking features to me is that the lobe of the amulet looks like it's almost fresh out of the box. It doesn't have much compression on it.
That's true.
The screws are very slightly offset, but I suspect that's because of the cable tension pulling the disc screw away. And that's obviously, as you know, one of the signs that there's compression. But the lobe itself just barely looks like it's compressed. So that would be another concerning feature.
Now, did the larger device seal?
No. And the disc protruded well into the pulmonary vein, so we had to take it out. I don't have a picture of that, unfortunately, but I'm telling you this is what
trust
happened.
Can I ask, were the measurements, I know based on 2D, were there 3D measurements or CT measurements for comparison?
So this is one of the discussion points that we're going to talk about relative to this case.
If we let you get there.
I have drifted over the past several years to doing less and less pre-procedural imaging. I have been guilty, I'm sorry. I have been guilty of doing very little pre-procedural imaging because we did a prospective study at our institution of randomizing patients to no pre-procedural imaging versus pre-procedural imaging, and found that our success rates were really no different, and the number of cases we had to abort was really quite few. So I've been going in that direction, but I'm going to tell you, after all this, I've now gone back the other way.
Quick question though, the procedural imaging, are you doing it with 2D or 3D echo? Is there any 3D component to it, to the procedural imaging?
Yeah, he just showed us a 3D picture.
Meaning for the baseline assessment.
You mean
with MPR?
Pre-procedural?
Pre-procedural.
Yeah, to measure the size, how an MPR gives
No,
you.
not really. I just the pre-procedural imaging is not done so much by me. It's just done in the echo lab, and you're talking about pre-procedural.
Oh no, I'm sorry. On the table, on the day of the procedure.
Imaging. Yes,
the preliminary imaging.
Yes,
yes, doing it with multiplanar reconstruction.
Yeah, absolutely.
Okay.
And for these cases, for this particular case, did you have a steerable catheter or was this a fixed curve? Only because it looked like on your first left atrial appendage angio, it didn't look like you were quite coaxial with it. Was that one of the
This is
issues?
the double curve.
Okay, so you're not a steerable.
Not a steerable.
Okay, in the interest of time, Cliff, if you can keep moving. We won't interrupt you, I promise.
Okay, so we've been to this. This just shows you the uncovered lobe, if you will. You can see that on multiple views here. The 3D, I think, shows it really nice. So here's the 3D image of this appendage. And I've given you a schematic of what it actually looks like in terms of my mind. So this is really two lobes that come off like two legs of pants with a very short waist. And based on what I had done with the amulet, I wasn't convinced any of the currently approved technologies would be able to treat this successfully. What does the panel feel about that?
So I have a similar case, so I won't divulge. So you'll hear it. I'm going after you as the third case.
Okay.
Oh, you're going to, today?
I'm going to present very similar
The
analysis.
same case. I'm
I don't know
sorry.
whether it's the same solution.
Anyone else have any notions what we should do?
Because I had one where we had something similar. How about putting two devices?
Good idea. Because I think that's the only, actually looking at this,
Yes.
this is the only solution.
Exactly, where you put two, and there were case reports of it actually, and you sealed both lobes.
So that's exactly what we did. So what we did was recaptured the disc on the first device, and we did a second transeptal puncture, and put the pigtail into now the other lobe, and are getting ready to deploy a second device. And what we chose was a 22 millimeter amulet as the second device based on some preliminary measurements, which I didn't really save. So what we did was take a second device, put it in the second lobe, and then we deployed the smaller one first, and then redeployed the disc of the second one. So it covered both of them. And there's your final angiogram on the right panel showing both devices. And I don't think you can see angiographically. I think it's a pretty good seal. And there was no obstruction of the mitral valve, and the pulmonary veins were clear. And here's the follow-up imaging. Top left panel was the deployment of the second device. The bottom panel are both devices, but still attached to the delivery systems. And then the bottom right panel is after both the cables have been released and the devices are fully deployed. There was a report. This is the only report I found. Although if you look in some of the registries, somewhere around 2% report two devices being used. So these were the learning points for me. That the morphologies are, as you all know, come in infinite sizes and shapes. No two are the same. The current FDA-approved devices are very limited in their adaptability. We got to be able to think outside the box. And the last bullet point is really quite important because, if a prior CT scan would have told me exactly what I was dealing with, and I probably would have known ahead of time what to do. But I learned it on the fly. And I just want to make a statement that currently HRS and SCAI, as part of that, are putting together a guideline document to guide left atrial appendage occlusion. And we had a lot of arguments about the importance of pre-procedural imaging. And it's interesting, there's really no data that shows that pre-procedural imaging is essential. We just accept it, but there's no data. So with that, I want to thank you all for your attention, and if there's any other comments, I think we're good.
So, Cliff, I think we're going to talk about pre-procedural imaging with a couple of the cases, but just in case it doesn't get brought up later, the discussion on intra-procedural ICE versus TE, using TE, I think that was all TE based, but the panelists, just to go around, ICE or TE for intra-procedural?
So I would say that really depends whether there is a pre-existing left atrial appendage sizing or not. If there is a pre-existing left atrial appendage sizing, particularly by CT, because in this field many people have already had atrial fibrillation ablation, therefore they already have a CT, so the sizing can be done. And if you have a good sizing, whether the pre-procedural T or PCT, then we can use even 2 DIs or 3 DIs. But we will not do a procedure and sizing of left atrial appendage based on 3 DIs.
So for most of our cases, we do CT pre-procedural planning. If it's something that looks like it will be straightforward, then we will consider using 3D ICE. Anything complicated, we would use TE for. Anything that doesn't have any pre-procedural planning, we would do TE-based.
So at our institution, probably about 2/3 get CTs ahead of time, but nearly all cases are done with 3D echo, with the 1/3 that don't get a CT with confirmation of sizing, morphology, et cetera, and then the other 2/3 that already had a CT, just confirming what's already there. Our bias has been that just with the emergence, we started to shift to doing more and more ICE, but there's enough data to tell us that even any PDL, all leak matters, even little leaks matter. So our philosophy has been that we want to see it as well as possible, and to treat it, prevent it. So that's why we do mostly TE for these cases.
Our default is a FIOPS CT pre-plan followed by a 3D ICE with the Philips VeriSight system.
In our institution, we do the CTs as well, but really on the table, identifying with 3D, I think similar to the other institutions here, confirming, because you have a lot of variation on the table. Patient has been fasting. You tend to have a smaller size as well, I'm sure. And some of us try to hydrate them, plump it up a little bit. And also the location as well, right, on CT, and kind of going back and forth, right? Vivian, I know we had a couple of cases where we go back and forth where the placement of the device, bigger device or smaller ones. And so really that interaction between the interventionist and us in terms of determining the size, but certainly 3D modality is the way forward, whether it's a CT or by echo as well.
All right. Our next speaker needs no introduction. It's Nadira, who's going to be talking about, she's got 2 talks back to back. And one is leak management and the other is device or fit or MisFit.
Thank you so much. And I think all the discussion really goes to this talk as we are talking about 2D imaging. And when Paul gave me this talk about device fit or MisFit, it got me a little confused. But I thought, you know what, I'm going to give you an example of an imaging roadmap, because really basically pre-procedural planning, as what mentioned by Cliff, so important. Makes or breaks the case from a Watchman device or any LAA closure device should be very quick, simple, 15 minutes instead of a 1-2 hour procedure. So really, pre-procedural imaging is key. These are my disclosures. So start off with a case presentation. So here you have a cardiac CT. The ostium is 25 millimeters. The length is about 25. The length needed you would need is 15.5 millimeters, and maybe we could use 31 millimeter flex. So this is what, going into a case, this is what we think at 31. On the table, doing a TE, 2D TE, you get 22, maximum ostium, length 24, maybe a 27 or 31. This is kind of okay. And then I would love I love my 3Ds. Unfortunately, you see the imaging really challenging, the windows, the resolution, really couldn't get a 3D MPR. Okay, so what do? We put in an ICE. And again, 21 millimeters, length 27, so we're like, okay, maybe a 27. Try to do a 3D MPR off the 3D ICE, still really hard. Couldn't get it, insufficient resolution for 3D MPR. And so then we went on to fluoro. Fluoro, knowing that single plane, aerial caudal, your maximum ostium 23, back to the drawing board 27 versus 31, Watchman flex. Okay, quick summary. So these are the measurements. You have CT 25, 2D TE 22, 3D we can't get, ICE 21, and fluoro 23. Which would you use to the panel?
Do you remember what the left atrial pressure was at that time? Was this person, like you mentioned, they come into the procedure, they're fasted. Oftentimes, we will get smaller diameters with TE, and we think that the patient was, not fasted for their CAT scan versus fasted on the table. And then the other thing is, we wouldn't base our sizing on fluoro, so I'm just gonna take that one off.
So I would say that actually measurements are in agreement. Because the CT measurements tend to be about 2 millimeters larger than TE measurements. Whether this is because people are not MPO when they have CT or not, but the overall measurements are actually in more or less agreement. 25. There is no big discrepancy in these measurements.
And it's similar to the aortic annular story, right? When we used to measure aortic annula way back with 2D TE and then 3D TE. CT is always a couple of millimeters larger, and then TEE is the next, and then 2D assessment is the third.
And I typically, depending on the device I'm using, if I'm using a Watchman device, I typically tend to be a bit more aggressive on the sizing. Amulet, I'm a little less aggressive. So if we're going with Watchman here, I'm going to use the 25 millimeter measurement.
That's right. So really going back to what we just mentioned to the previous talk, really that CT, that 3D modality that we should really advocate. And I agree with Mo's point that's around the ballpark, but really in terms of sizing, the limitations, just showing all of you the modalities of it and the limitations of each and every modality, that we should be going in a 3D in terms of measurements of this left atrial ostium, whether it is by CT or 3D. If you're limited by TEE during the procedure, certainly go back to your CT. And for this, we move forward. When with a 31 millimeter Watchman flex, we had both TE and ICE, since we already opened up, just showing you the comparison of the TE and the 3D ICE biplane imaging. So certainly, fits very well, 31 millimeters. It was just one single deployment, wasn't difficult at all. Using both TE and ICE. Measurements as well, which I'll talk to you about ICE imaging in the next talk. Really measurements of the ostium borders as well. You can see that it's similar in terms of the measurements, both in 3D TE and ICE biplane, about 24.5 millimeters. And back to the point of paravalvular leak, very important in terms of determining no leaks, to what Costa was saying. No leaks, color Doppler, looking at by 2D and 3D as well, making sure on 3D the device seats very well as well. And ultimately fluoro, which you want to make sure that there's no leak. There's a complete angio of it. You can see beautifully seated, no leak as well on fluoroscopy. And so back to the point, as you guys all know, interventional echo is similar with Mo and Costa, that we mentioned just now about 3D TE acquisition with NPR, really important. If you can get a good view, 2D, just click on your 3D zoom, you get what you get on the left-hand side. And right now, the vendors, especially Philips, have the auto LAA measurement for you to actually do a quick measurement of the minimum and maximum diameter, as you see on the right-hand side. It's just a quick button right there on the console to get your min and max measurements with the alignment of the crosshair at the ostium of the left atrial appendage. Really important. So here you can see on the left-hand side the landing zones for this patient. You can see the min and max diameter of 25 by 18. You can get the perimeter as well that it gives you. The landing zone, you can zoom up in terms of the green plane, 17 millimeters, the red plane as well, 17 millimeters. It's a 3D perspective, similar to cardiac CT. So if you don't have a cardiac CT, pre-procedure planning, rely on 3D TE and 3D NPR. And so for this patient, it's a 27 millimeter Watchman flex. So the key points for this is really in terms of imaging. 3D CT or 3D TE certainly supersede 2D measurements. I know Watchman does that 0, 45, 90, 135. Really, ultimately, your 3D measurements go above it, beyond, and in terms of depth as well. And really, the reason for that is because of your high spatial resolution with cardiac CT, and also like what, to Vivian's point as well, these patients are hydrated for your CT scans, so they are really plump. And these patients have been fasting for the procedure since midnight. So these patients, you can actually give the IV fluids during the procedure or before the patient is wheeled into the room, just to make sure, and you can also check the left atrial pressure as well. And then the other thing, imaging with precision drives success. Know the strengths and weaknesses of each of the modality that you have, and really choose one that is practical to your program, and work with your interventionist and understanding the limitations and collaborate with it for really that mutual understanding, like any structural procedures. And ending with a Benjamin Franklin quote saying that failing to prepare is preparing to fail, basically, and really select your best imaging roadmap to guide a really successful Watchman procedure, and really makes a difference to a 15-minute case instead of a 1 or 2 hour case. With that, thank you very much.
Any questions, comments from the audience? Please feel free to put your hand up. We'll bring a mic to you. Costa, did you have a comment or a question?
Yeah, I'll make a quick comment. So, one additional workflow that we haven't touched upon is the utilization of the newer mini, we call them pediatric TE probes. So really, they're not. They're just miniature TE probes. Really, they've gotten to the point that in the past there was a big difference between using the adult probe and the smaller probes. The spatial resolution, it just wasn't as good. We've now, from a technological standpoint, we've gotten to the point where these probes are excellent. So this idea of the inherent inefficiency of putting someone to sleep, doing full anesthesia, TE, et cetera, waking them up again at the end of the procedure, really turning a 30-minute case, 30-minute case into an hour-long, song and dance. I think there's an opportunity to go beyond that. I think these can be done with conscious sedation using these these mini TE probes. So we're excited to try that basically at our institution. And I think it's a nice marriage of having as good image quality as possible, that we get from a transesophageal probe, to marrying it with the efficiencies that we have of just not doing general anesthesia, for every single one of these cases. So,
I think that's a really good point, because I think it's important not to assume that, less invasive or smaller imaging catheters are necessarily going to be more efficient. There are plenty of places where GA and TE, and they're doing 8 cases in a day in one lab, and there are plenty of places that can barely get through 4 ICE cases in a day. So I think, and you touched on this point earlier about PDL and DRT, at the end of the day, this is an elective procedure. And so the threshold for success is very, very high. We're not saving lives acutely. No one's coming in decompensated, needing a left atrial appendage closure. And so I think whatever it is you choose to do, I think the first metric that has to be achieved is technical success safely, regardless of whether that's adult TE, mini TE, ICE. And that's where I think, these discussions that Cliff alluded to, that we're having these robust debates as we're writing these guidelines, is the importance of pre-procedural imaging, intra-procedural imaging, and post-procedural imaging. And ultimately, whatever modality you choose, do what you do best to give yourself the best procedural outcome. Nadira, do you want to carry on with your second case?
Sure.
I mean, not only is it, sorry, one other thing to add is not only is this an elective procedure, but it's also a prophylactic procedure. We are preventing stroke, so the onus is even higher. Safety becomes paramount.
No, great point.
Can say about the mini probe is really mini TE probe, rather pediatric. Mercifully for us, adult echocardiographer is really, so there was a big discussion how this mini probe will have assignment of wheels. And it really is, assignment is exactly as an adult probe. Big wheel is anteflex, retroflex, and the small wheel left to right, as opposed to the pediatric orientation where the big wheel is the angle. So it's really help us adult cardiologists.
And I want to thank Mo as well, because for pioneering and working with the societies, the American Society of Echo, in terms, I remember me reading about it when I was a fellow. So, thank you for really putting forward in terms of echo imaging in this left atrial appendage. So thank you so much for doing all that. And now it's the fruits of it. To my next talk, it's something which we all mentioned, I think just now discussed. Really, 3D ICE. As you all know, I love my ICE catheter very well for my tricuspid, and similarly as well for the left atrial appendage. And I think it's more robust with the left atrial appendage closure in a lot of institutions. But certainly, I personally feel there wasn't a workflow that was available for me. I remember when I first started, I remember we in Columbia with Vivian and Bob Summer, I could not pass the TE probe. We tried everything. And we were kind of stuck, and I was like, okay, that was when the 3D ICE catheter just came out, literally just came out, their very side. And so I kind of wing it with Bob Summer and her, and we did it. And so certainly there was a clear indication for raising awareness, not only awareness, but the need for really a workflow, similarly for the tricuspid, which we have published. And so this is what I want to share with you in collaboration with Philips. So here, as they mentioned just now, the case planning. You heard about FEOPS. So this is a case where, thanks to Matt Price for sharing this with me, a CT pre-procedure planning for FEOPS, as mentioned by Ashish just now. You can do a lot of it with the software in terms not only sizing as well, the diameter by 26 millimeter for this case, and also pre-procedure planning. What kind of catheters you can use in terms of delivery as well. The transeptal puncture, where would you aim for the transeptal puncture as well? And for this patient, you need a 31 millimeter fax. So really going into the procedure, you know what are catheters you need, where to do your transeptal puncture. And so for 3D ICE imaging, first thing, similarly for TE, ruling out the left atrial thrombus, right? So you know that this patient has CT before procedure, whether it's a short period of time or a lengthy time before the procedure, you really need to determine that there's no thrombus. And also they had a short interruption to their oral anticoagulation. And noting with 3D ICE, it is a far field. And so really in terms of evaluating your left atrial appendage, you kind of need to go transeptal into your left atrium to really assess the left atrial appendage to evaluate making sure that it doesn't have a left atrial appendage thrombus. The other thing you need to make sure before you start puncturing is making sure that there's no pericardial effusion. So you can do that with your 3D ICE. Bicaval view, similar to what you get on TE. You clockwise from your home view, RV inflow, outflow view, like the tricuspid, clockwise posterior flexion and slight right flexion, and you advance the right atrium or your SVC junction. So still in the right atrium, making sure there's no pericardial effusion just to start before you start the case. Doing a transeptal with your eyes guided, this is similar to your TE, bicaval view on your left-hand side. The only difference is that your right atrium is at the top, not at the bottom. Just note that your right atrium is at the top, your left atrium is at the bottom. In terms of a bicaval view for your ICE catheter, you can biplane your imaging similarly for your TE to 45, 60 degrees, and really identifying that tenting that you want to see similarly for your mitral clip cases of your transeptal puncture, as indicated by the yellow arrow. And then you advance your 3D ICE catheter into the left atrium using fluoroscopy. So you can see moving to your RAO counter or clock or counterclock your catheter to align with the wire, back to your LAO view and advance the catheter into your left atrium, and really using ICE imaging to directly image your left atrial appendage. Putting in the sheath and also your pigtail as well into your appendage for your angiogram. You orientate your ICE imaging plane to really be coaxial with your left atrial appendage. So that is your baseline imaging. Now going back to your 3D ICE. So imagine this, your 3D ICE imaging of your left atrial appendage different from your TE. You only have 0.45 and -45 in the anterior and posterior view. So the views that you get on TE, the 0, 45, 90, and 135, really does not apply to your 3D ICE measurements. It doesn't. But what Philips have come up with is equivalent to your basically 0, 45, 90, and 135. And the mnemonic for it is actually called MAPIT. So which means your mid-left atrium mitral, your 0 degrees on 3D ICE, your equivalent view is actually 90. Your mid-LA aortic valve at -45 is equivalent to your 45 degrees on your TE. And your mid-LA Pulmonary artery at plus 45 is equivalent to your 135 degrees on your TEE. So literally, we kind of map it, essentially. Just map it. Mitral, aortic, and pulmonic. Exactly. Your 0, 45, and minus 45. You get all your views, the basic measurements on 2D, and I'll show you an example right here. This is your baseline left atrial appendage assessment on 3D eyes. 0, 45, and minus 45. You identify all quadrants of your left atrial appendage by just finding one on 0 degrees and then rotating your second plane through your positive 45, minus 45, or your plus or minus 90 without moving your ICE catheter. And from this view, I tell my interventionist, don't move. I know Costa and Paul knows that. Freeze. Froze your ICE catheter. That's where I will do my LAAC ostium diameter and depth, just from this view, by biplane imaging or also by 3D MPR, which I can do as well on your console for your 3D ICE measurements. And for this patient, we implanted a 31 millimeter Watchman. That went well. The same steps that you do for your TEE, you apply it for your 3D ICE catheter. Fluoroscopy here, well-placed seated device, no leak at all. And then you want to confirm similarly for your TE, the pass criteria, positioning and seal. Similar views, 0, 45, minus 45, you align the catheter to face the length of the device. You rotate the X-plane throughout all other 3 quadrants and place your color flow. Like what Costa mentioned, you want to make sure there's no leak around the device, it's seated well. This is all done after tugging the Watchman device to make sure that it seats very well. So position and seal with color Doppler. You want to make sure as well the compression, it sits really well. So for this device, you just do the measurements on 2D here. And here you can measure it, and this patient has a 14 to 21% compression, adequate enough for this patient. And then finally, after release, you want to make sure the images, the patient is seated well. These are the final images after release, both on ICE, and you can see on the fluoroscopy as well, on the right-hand side. And then don't forget, with the 3D ICE, you want to check the interatrial septum and also the effusion as well. So you want to make sure it's not a bidirectional shunt. So you move the catheter back into your right atrium, clock past the mitral valve and posterior deflection, put color Doppler there, you can pulse it. On the right-hand side, to make sure there's no effusion, just anterior flex to look down on the mitral valve and make sure there's no pericardial effusion. And after that, that's it, and the patient, that was a success, and all done with 3D eyes. So really pre-procedural planning with CT and some of this imaging modality like FEOPS really help improve the workflow. For transeptal, for 3D eyes, similar views as the TE, just the switching of the RA and the LA, and try to find a 3D eyes catheter position that directs the imaging volume at the face of the device once you do the transeptal into the left atrium. And to Rahul's point, certainly has revolutionized, in the way that we operate Watchman on left atrial appendage closures in the cath lab, moderate conscious sedation, rapid room turnaround, same-day discharge. But really, this is a learning curve. It's not just by the first case you can do this. Learning curve, work with your team, interventionist, anesthesia, to get to the stage of moderate sedation and efficiency and same-day discharge. This ICE imaging protocol, thanks to Philips, it's actually available. It's actually in publication right now, a review, certainly available to approach to all of them in terms of what are the steps needed for the 3D eyes only imaging protocol for the Watchman. With that, thank you very much.
So I think we've also switched to a very similar workflow as you, Nadira, and yeah, we were using FEOPS for quite some time. I think one of the limitations of the CT pre-planning software, at least I found, is in a very heavily trabeculated or pectinated appendage, because the modeling of the different sizes and devices that you use, I don't think it takes into account deformation of the valve asymmetrically that might exist if the feet don't expand, in a Watchman, or the lobe is sort of not symmetrically compressed. It's sort of an all or nothing when I look at those pre-procedural sort of models or modeling of how the different devices and sizes work. So I still think that's a limitation at the moment in some of the CT pre-planning. I don't know what others think about that.
Yeah, I think with the CT pre-procedural planning, it also, it can predict where you should do your transeptal puncture. Doesn't necessarily tell you exactly where you're going to end up in that relationship to the appendage and how that's going to affect orientation. Some of that difficulty will be taken away as more sites have more steerable catheters, and that becomes less of an issue. But I'm also wondering how much of the audience or how many people in the audience are using ICE for their left atrial appendage closures? Zach? So not that many. I do think that ICE is helpful. As you mentioned, we had a case where we couldn't do a TE. We're seeing more and more patients who have contraindications for TE guided procedures. I think for anyone who's trying to learn how to do ICE-guided Watchman procedures, it's important to learn what's the equivalence, right? And so you don't have the 0, 45, 90, 135, as you mentioned, and oftentimes it's the interventionalist controlling the ICE catheters, right, which can be very frustrating for our imaging colleagues sometimes. And so I do think that with the learning curve, it is worth the investment of doing TE and ICE while you're learning how to transition to ICE procedures, so you can figure out what is it that correlates to a 45 or a 135. And yes, Philips has this algorithm and the pre-procedure or the procedural algorithm, but does understanding that yourself as you're manipulating, and that way you also have a fail-safe, right? There's less pressure for you learning that particular technique.
Paul?
I mean, I'm just asking. So, just hearing what you're saying, if you get past the learning curve, is there any patient you cannot do ICE in? I mean, is ICE just going to be the future then?
So I think it goes back to what Rahul and Costa were saying. This is an elective procedure, and so I think we're going to have multiple options as far as what is optimal for each site, right? This is an elective procedure. You want to make sure that you don't have any leaks. You want to make sure that you provide the safest option for your patients. If for your particular center, anesthesia is not an issue, getting imaging is not an issue, I do think TE, it does give you better images and is less technically taxing for the interventionalist. If those logistical issues become a problem, then yes, I think 3D ICE gives you an excellent option. And then, of course, there's also going to be patient characteristics if anatomically they can't pass the probe. For us, the patients that we, based on CAT scan pre-procedural planning, that we won't do ICE on are the difficult anatomies, the retroflex chicken wings, the ones with questionable depth, the ones who, we're questioning whether or not there could be potential thrombus on the CAT scan. There's potential slow flow, but we really want to further evaluate that. I think that can be difficult sometimes on ICE ahead of time, given that you're imaging from the right atrium and doing it far field. And then you could do it once you've done your transeptal puncture, but that's, then you've already done a puncture in that patient, and you do have to be very careful then after your transeptal puncture, if you haven't cleared the left atrial appendage, to make sure that none of your equipment accidentally goes into the appendage, right? Because we're all very focused on getting that, amazing transeptal puncture that orients you directly into the appendage, and oftentimes we're not watching that pigtail wire and it's going into the appendage before we've cleared it.
I think just to follow on from that, at the moment, we're looking at all this in the context of 2 commercially available devices, but I think as we see novel approaches to left atrial appendage closure, which perhaps rely less on, whether there are multiple lobes or complex anatomy, laminar is a good example of where you really can stay quite proximal and then exclude whatever's happening beyond. That may also change the applicability of ICE, as well as, the ability to treat a wider range of populations. Cliff showed a case where it was less than ideal, but, he got away with it and did a great case, but clearly there's still an unmet need in terms of the perfect devices.
So there've been so many meta-analysis that compare the two, and the procedural success rate is no different. Everything favors the ICE catheter. So, why is it not very universal? And it's much. They may not be prospective, but all these meta-analysis support the ICE use.
So there are multiple answers to that. First, I would like to really say thank you and appreciation to our electrophysiology colleagues who are extremely facile with 2D ICE imaging. And my prediction would be if at any part of a structural field that the 3D ICE will penetrate the fastest will be an electrophysiology field. With respect why it's a 3D ice, aside from the cost of a 3D catheter, it's also 3D imaging is really one complete level up above from 2D imaging. I work in a tertiary institution. I have 20 plus professional echocardiographers, of which probably only half a dozen can routinely do good 3D imaging. So even in professional imagers to do 3D is not easy to jump into 3D. And that it's up to us imagers to actually educate people how to do that.
Yeah, I think in our center, we used to do like 5 cases a day, and we alternate between EP and myself. So we started using ICE, and obviously it takes time. And then to do a good ICE, crossing the septum and looking at the mitral view, looking at the 135 is the key. That was always a challenge. The EP, even though however expert they were, it was taking at least 45 minutes to kind of get there. And then most of the time we couldn't see shunt, and then we switched over to TE sometimes. So sometimes that's what was the drawback, and after a lot of back and forth, we just switched back to TE. So it's all like you have cases lined, and it's not that each one is better than other, it's just how we can get these cases done and what's the efficient way.
One other aspect that hasn't been talked about is the fact that it's not always a slam dunk getting the ICE catheter into the left atrium. Oftentimes you do need to balloon the septum sometimes, and other times you do spend some time trying to track it. Nadira gave some good hints and tricks of how to do that. Starting low is one good example, and then going anterior, following the wire, going in the RAO and LAO to see if it tracks would help. So I think that's, then the fact that now you, with the 3D ICE, the concerns that you had of going underneath the mitral to get that 135, et cetera, is mitigated. You can just pretty much sit there and play with the console and the knobs, and you pretty much get the -45, the +45, like she said. So I think the 3D ICE, I know is a game changer, and I think along with CT planning will become the default way to do these down the road.
I would like to ask the panel a separate issue. You know, I've begun training the interventional echocardiographer to manipulate the ICE catheter, and I want to know whether anyone else does that. I mean, I wanted to keep their interest in ICE, particularly when it comes to 2D for like PFO, ASDs, and I want to know whether anyone else does that. They seem to like it.
I do, and certainly when we were evolving our program. Yeah, we do.
Well, that's what I'm talking about.
And we have our fellows, our imaging fellows, actually scrub and learn how to manipulate the ICE catheter. And I think it's helpful, even if they never use it again, just to understand what we're trying to do to achieve those pictures. And then it's just a bandwidth issue, though. And then, of course, we haven't discussed the RVU, issue, which is a big, pain point in structural cases for imaging in general. And hopefully that's going to change with time soon.
And one thing please Costa and Mo as well, say something to this, because I feel as an interventional echocardiographer that feeling the catheter, I can understand, besides the simulation before going into the case, and I think certainly helps me. And sometimes I will tell my interventionist, okay, do this, do that, because you understand what movement and with the imaging really helps me as an interventional echocardiographer. Costa.
Yeah, it's you bring up a good point. So at our institution, EPs, of course, are the masters, right? And then you have ICs who have done a lot. They also tend to get very good. But, just to take to go along with the theme that to what you're alluding to. So I was a novice, and then started comparing myself to an IC novice. Both of us getting our hands on 3D ICE at the same time. My ability to pick it up and to do whatever maneuvers I needed to do to enhance the image, to get the image, whatever, it was much easier for me. It was much more facile. And I think it's from experience doing other things like transesophageal echo, or having just a 3D understanding of, a 3D ultrasound understanding of what the heart looks like. So I think it can be done, but it does get back, and we've done that. We've tried to do that as much as we can, with one of us scrubbing to actually do the ICE, but eventually, the pressures of clinical medicine are such where, if I could have Rahul do it, because one of us needs to be on the console, or a sonographer needs to be on the console. So that really have two people, scrubbed, ends up being too much, unfortunately.
So there are several obstacles to using professional imager for 3D eyes. One of them is hospital privileges. Most imagers don't have privileges for invasive procedures, and the other would be malpractice coverage. Also would require malpractice coverage, and that negotiated. And then third, as you said, is really scrubbing and a sterile field. What we were considering, and we are still thinking about that, to instead of a transfemoral access, to do transjugular access, and then have the probe outside the sterile field and manipulation from the outside field. That would lead then the images upside down, so 3D eyes images are already difficult, so there'll be even more. But those were the possibilities of that institution.
Perfect. Okay, wonderful cases, thank you. We'll now move on to Mo to talk to us about a new technical boundary crossed with left atrial appendage closure.
Okay, thanks. So it's interesting. I mean, we didn't coordinate. We have a similar case, so we'll have different experiences, but we'll see that both led to success. So first, I'm an imager. I'm an interventional echocardiographer and interventional imager in general. I'm not interventionalist, so I'll provide you the imager's perspective to this, and I'll touch upon different imaging modalities in this talk, and I have another talk in the next session, so we'll expand some more. And so these are my disclosures. And so I'll start with the case presentation. Real case, 85-year-old, atrial fibrillation, complex past medical history, of which I chose only two elements: aortic stenosis that was treated with a self-expanding TAVR, and a complete heart block with the dual chamber pacemaker. The only reason I'm mentioning that because those might interfere with our fluoroscopic imaging, maybe help us, maybe be an impediment. With respect to left atrial closure, his CHA2DS score is 4. He had frequent falls and frequent GI bleeds, so it seems reasonable indication for transcatheter left atrial appendage closure. And he was referred so I was asked to evaluate his CT for pre-left atrial appendage closure procedure. And when I say I was asked to evaluate CT, not necessarily that we order de novo CT, because the patient has atrial fibrillation ablation, so there was already a CT, and we can just then piggyback that CT, which really helps in this field to decrease radiation and inconvenience to a patient. So this is CT, how I evaluated. And when I look at the CT, the first thing what I do, I like to look at the 3D anatomy of the left atrial appendage, sort of a big picture of the left atrium. And I like the first to put it in a full left lateral view. So then it's really how is the anatomic orientation of that left atrial appendage, relationship to the pulmonary artery. Maybe it's not as important for transcatheter Watchman and amulet. Maybe it was very important for the lariat procedure. But in any case, we will get general aware. And then I will actually turn a little bit even more to extreme left LAO position. Maybe fluoroscopically this is not achievable, but CT is achievable because that will reveal more details of the left atrial appendage. And here you can see first the body of the left atrial appendage, and you clearly see that it's a bilobe left atrial appendage. There is lobe number 1, and then there is the lobe number 2. And you see not only that there are 2 lobes, but the lobe number 2 is folded onto itself. So mercifully, that very complex distal anatomy often is not completely relevant to closure. Might be, but often you will see these secondary or tertiary lobes where may not be important. But at least now I have a big picture that it's a bilobed or bifid appendage. Bilobe 2 lobes or bifid split into 2, whichever you prefer. And then, as we mentioned previously, when we do measurements by CT, we have to bear that it's about 1 to 2 millimeters. Those measurements on CT are larger than on TE. And then, using software, you can actually look at inside the heart and then first show the anatomy of the orifice. And here, this is an ovoid orifice, which always is much more complex than when it's a circular orifice to closure. This is sort of equivalent to 3D zoom view on TE. You see the Coumadin ridge, you see the left upper pulmonary vein, as well as left atrial appendage. And also, it's if you pay attention, it's really the orifice is always like a spirally closes in. if you already paid attention, sort of like Fibonacci curves. And then instead of, Nadira showed beautifully CT measurements the way radiologists did. But, I'm not a radiologist. I'm an echocardiographer. So instead of doing measurements, CT measurements in their projection, we actually use a simulated TE. We use the software to extract TE images in a TE-like. And these are all 4 canonical views, 0, 45, 90, 135, 4 angles, 45 degrees apart. And these are the number that I give is the landing zone diameter. But as you know, the 0 degree is really the most challenging because there is no distinct anatomic marker. So they will disregard it often 0 degree, but you can see the range is between 20 and 26 millimeters. And if you say that it's a 2 millimeter more than on a T, so then a T equivalent would be 18 to 24 millimeter diameter of this left atrial appendage. And then if you look at on 135 degrees, the depth is about 10 millimeter. Not good. Yeah, that's really challenging, but we say, okay, maybe we can try. So what did we conclude? Essentially, it looks like that by these measurements, just as in your case, we just happen to be on either 25 or 28 millimeter amulet device. So, but what was the pre-procedural caveats? I mean, it's really, so on CT I showed you LAO projection, but then I like to turn it into areocaudal view, which is equivalent to fluoroscopic views. So that's important that I, as a CT interpreter, speak the same language as fluoroscopist. So this essentially, you see then lobe 2 is closer to the pulmonary artery. That's the one that is folded onto itself. And we have a lobe 1, and we have a position left circumflex artery, and you see the depth is really about 10 millimeters. We don't do full measurements and don't rely on a 3D rendered image because that is strongly dependent on the gain. You can make smaller or larger, but gives you a big perspective how this appendage looks like. So then when we chose the amulet size, we that the amulet comes in 8 sizes, and there are 2 cleavages along this diagram. One is the size of the disc relative to the lobe. 22 to 25 is the separation between smaller and larger devices. Disc is 6 millimeter or 7 millimeter larger. And then there is the other cleavage between 25 and 28, whether it's a larger or smaller sheath, 12 French to 14 French. And you see the minimum diameter is between 10 and 12. So we are really on the 12, on a 10 millimeter, but we are considering 25 or 28 millimeters. So we are really on the shallow side of this appendage. So maybe we should try. So now we go to intraprocedural TE. So now we do exactly the same, 4 angles, 45 degrees apart. And again, so depth is again 9 millimeter. So it's a pretty in agreement. You see it's between 18 and 25 millimeters. So it's really in the same ballpark. And again, would be the same that we go for 25 or 28 millimeter amulet device. Okay, so let's try to do it. Okay, so this is intraprocedurally. We did also 3D TE, and this is 3D zoom imaging, and you can see that the bilobe appendage, lobe 1 and lobe 2, and this is not one pectinate muscle. I mean, it's not many pectinate muscles as you showed in mine. This is really like a ledge in between. Okay. So by the way, I always like when I give a talk, is there anybody who can tell me what does the word pectinate in Latin means? And I usually give $20, and I haven't gone $20 yet. And I have been pretty much around the world. Anybody? Means a comb-like. So if you look at the 135 degrees, when you see those like this, it's really comb-like. So at least if you didn't learn 1 point, take it at that. And then we can do a left rendering, but you truly see that this is really a bilobe. You see really there is a ridge into 2, as in he pointed out, this is fancy pants. But then we can use this, before that we can do 3D TE to actually render this, not only the orifice, but you can do this essentially really fancy pants. Lobe 2 and lobe 1, remember pulmonary artery is on the right, and then mitral is on the left. So therefore this is 135, but we have to speak the same language as interventionalists. So that will rotate counterclockwise in Z to get exactly what the fluoroscopic view is. Now, so we have exactly fancy pants. but in a 9 millimeter depth. So maybe, okay. So if you, by the way, if you want to do like these 3D images, my colleagues and I wrote a couple of papers, so these are the 2 latest papers that if you like, you are free, and I'll speak about them in my next talk a little bit more how to do it. So now we're doing to the lateral procedure, and then I say take 1. You know, remember if I say take 1, maybe, you know, that's not that simple, huh? This is the take 1. So we'll try 25 millimeter amulet. So let's see what we did. Maybe it was successful. Okay, so this is the standard. I'll just show you a few steps. We are in the amulet ball and a counterclockwise rotation toward the anterior lobe, or lobe 2 that I called. It's close to the pulmonary artery. It's pulmonary artery on the right-hand side. Then we go into a disc. Into the lobe. Now that's a lobe. Huh? We have decided, you already see that may not be, and then we deploy the disc. It's a challenge, huh? It's maybe not completely optimal. So at first in the low angle, you see that the disc is not above the Coumadin ridge. It's pushing on the pulmonary vein lobe. And on the high angle, you see there is a lack of contact between the lobe and the tissue. And also the whole device is rocking. That's not good. And also you see that pectinate muscle is actually pushing the lobe upwards. So it's not good, huh? And then we do tension test. See a little bit, we optimize the disc at the low angle, but on the, now it's even more. See that the lobe has moved into the left atrium, so it's really, and on top of that, there was no significant compression on fluoroscopy. That was sort of very similar to what you have. So we said that, okay, we failed. So we bailed it out, we took out the device, and then we go to take 2. So now we have 2 options. So maybe we should upsize to 28, because we said either 25 or 28, or we can do something else. And of course, when I tell something else, it's going to be something else. Because we said, what's the point in using 28? Because it requires the same 12 millimeter depth. If anything else, the shoulder will be even bigger, so we have to do something else. Okay, so let's see how we did this. And then as in my colleagues, so essentially we independently cannulated. Sorry, let me just, can I go back? So we independently cannulated 2, and it's an areocaudal view, and you see that the evolute valve is not cooperating with our visualization in this view. But actually, you see they're individually cannulated now, and then, but see what the difference, I think, between your procedure is that we really removed the original device. So now we are doing that, we're going to do 2 separate devices, and we chose 2 16 millimeter. So 16 millimeter is the smallest amulet device. And then you see now I zoom this image, and you actually see them before we have released them. And then now I'll show you simultaneously we're doing TE. But you need now switch. With most of our procedures, we do 45, 135. But for the reason that you beautifully showed that the map, we should use those names, which I'll address a little bit later. But essentially, you always essentially look to find the angle that shows you the best representation of anatomy. And see here, we're actually doing it 0 degrees. And that because now we can really see 2 fancy pans, lobe 1 and lobe 2. See now it's 0 degrees, so lobe 2 is on the left side of the image. And then you see as we are deploying 2 devices. So naively, we have done hundreds and hundreds of these cases, but this is the first time we did it side by side. And I naively thought, you put one device and release it, and then you put the other device. But of course, that doesn't work like that. So essentially, you see there's 2 devices, but essentially first you deploy lobe number 1, then you deploy lobe number 2, and then you deploy disc number 1 and disc number 2. Is that okay, from the interventional perspective?
Yeah, since they're the same size.
Yeah, the same size, yeah. Okay, so I'm not misrepresenting my interventionalists. Okay, good. Okay, so now it's really now they are released, and you see now we are no longer, because the valve was interfering with this, we now moved in a sort of AP view, which we'll often do an AP view, because at the end of the procedure, because then we can use the simple chest x-ray to compare for the location of the device. And now this is all two devices, they're offset. Is good position? Okay, thank you. Okay, so this is really nice. Okay, and then now this is amulet 1, amulet 2, and then if you want a 3D, it's really like a one on top of the other. Nice, huh? This is amulet 2, that's the one close to the pulmonary artery. And then from start to finish, we started with the bilobe or bifid appendage, and we ended up with the side-by-side 216 millimeter amulets. So what I conclude, okay, so from a bifid to 216 millimeter amulets, but I hope I convinced you the importance of multimodality imaging between echo, fluoroscopy, and CT, and importance that we all speak the same language. So I hope you enjoy it. Thank you very much.
That was a fabulous talk. I think the last talk is Jason. I don't see him. Is he here? Jason Rogers? He was here. He seems to have left. Maybe we can take some questions and maybe text him if he's...
So do you think you could have done that with Watchman?
So the question that Costa asked is, could he have done that with Watchman? Oh, here he is. I think, nope, not yet.
So could we done? That also depends on the availability of the representative. No, they're still, yeah, I mean, that we do for these, we do after 3 months.
So when you measured for the two devices, you didn't measure the true orifice, not the waist, you measured the orifice of the lobe, and you sized
of the leggings. We measured the leggings, essentially if there's a fancy pants, rather than the waist, we measured the leggings. And plus 16 millimeter is the smallest device.
For these type of cases where you now have two devices, what type of anticoagulation profile do you do? Or do you become more concerned that the endothelialization may be a little bit more delayed? So any
it was a sample of 3, isn't it? He showed one case, I showed one case, and there is one published case. So I would follow exactly what for amulet devices. I don't know whether it's a dual antiplatelet therapy. Yeah, so it's very.
All right, Jason's here. So without much ado, he needs no introduction. He's going to be talking about some new techniques.
Okay, thank you. We're running ahead of schedule here. So my name is Jason Rogers. I'm an interventional cardiologist in Sacramento, California at UC Davis Medical Center. And the title of my talk assigned was a new technique for LAA closure. And what I want to talk to you about is a new technique for left atrial appendage exclusion called the laminar procedure. How many of you in the room have seen a laminar procedure ever before? So, okay, great. So this could be new to a lot of people. Here are my consultants. So the inspiration for the laminar procedure was that the appendage is essentially like a small sac. And how would you close a sac? So one way would be to put something in the opening of the sac. But that's not really how we close most sacs, right? You could roll it up like a sleeping bag. We thought actually the thing that made the most sense was you would just twist it like a bag of bread. So you twist the bag, the opening closes, and then you can kind of lock it closed. And the advantage of this would be the same type of rotational process for any kind of bag that you had. The mechanism would be the same. And that's what we developed here and the team, and you can see these static images show the concept. So we have an atraumatic nitinol ball, doesn't have any anchors or barbs, it's just got some frictional elements. You put it in, you rotate counterclockwise, the appendage closes like a bag, and then you lock it shut. So this is kind of hard to get a sense of, so I included this kind of benchtop cadaveric demonstration, which I think explains a lot. So this is basically a cadaveric left atrial appendage in a pressurized system, and you can see the ball being entered on the left, and when it's rotated counterclockwise, it doesn't take a lot of forward pressure or contact to really just engage the appendage tissue, and when it wraps, the ostium comes in and it just closes off. And it's reversible, as you can see. So on the right, we see the appendage before, and then after the lock is in place, that's what's left behind exposed to the left atrium. So it's a very low surface area. This is the animation. The approach to the appendage is really the same. We do a consistent inferior-posterior puncture. We don't really tailor mid-mid or inferior mid because it has a steerable guide that allows us to steer the device. We really come in the center and very orthogonal and just touch the back wall. We don't go into the appendage very deeply, and when we rotate, it closes, and then you can deploy the lock. Up until this point, this is all reversible, and you could remove the device up until the moment of release here. And like a bare metal stent, we, at least in animal studies, we know this heals very, very quickly. No, I'm not sure what that. No, because the ball and the lock are locked to one another, so they can't rotate independent of each other. So when the tissue's locked, it doesn't rotate. So this is the delivery system. There is a stand. There's a steerable guide and a delivery catheter which allows you to rotate and deploy the device, and it's 18 French OD. So for the early feasibility study in the US, we had two device sizes, a 12 millimeter diameter ball and a 16 millimeter diameter ball. We will have two additional sizes in the pivotal trial. And so I would like to show you a quick case that we did at UC Davis as part of the early feasibility study in the United States, 87-year-old gentleman, usual indications for commercial left atrial appendage occlusion. And screening can be either TE or CT. Here we use CT, and we're getting about 25 by 21 for the ostial size, plenty of depth. The depth is measured a little different for laminar. It's a orthogonal perpendicular to the ostium. You're not going into the lobe, you're just entering straight in. So 25 by 21, this is a rotational image of the appendage. You can see there's a lot of distal anatomy, which is not really relevant. These are the static images that we're more accustomed to on the table, 0 and 45 degrees, and then again 90 and 135. And like some of the other cases we've seen, there is a prominent pectinate on the 135, and that's really the problem with CT, as Rahul mentioned, that you just often don't see these pectinates, and Nadira as well. I mean, it's I think a limitation of CT, and we've tried different gain settings and everything, but we're often surprised that there are some more prominent pectinates. But in any case, the depth here to the pectinate, which is where we put the ball, is about 9 millimeters, and the ball's only 8 millimeters tall, so there's still plenty of depth here. 3D MPR, we're again getting about 26 by 20. Remember on CT, it was about 25 by 21, so really getting about the same ostial measurements, and that's how we size the device. It's mostly related to the size of the ostium, is the size of the ball that we would use. So here's our inferior posterior puncture. Once we're in with the steerable guide, you basically unsheath, in this case, a 16 millimeter ball in the left atrium, and you can see that it just expands, and it's pretty atraumatic. The front is, very flat and smooth. And then it's just a matter of steering this to the left atrial appendage ostium. So we work in the 45-135 X plane, and we can toggle with 3D, and you can just see exactly where you are, and it's very easy to center this up in the ostium. Once you're centered, you just advance that in, and you can see on the bottom that we're making contact. In this case, we're contacting right on the pectinate, so we're right in the center there. In this case, we had to apply a slightly more forward pressure to engage the pectinate. Usually it's laying more on the flat back wall of the appendage, and it's not so much required. And then to confirm, people always ask, how do you know you're touching the back wall? We do a little angiogram. So there's a contrast lumen in the catheter. We can do a little injection, and we can see that the ball is touching the back wall. So we've confirmed on CT, on TE, our image position, and then here we're just confirming that we're contacting the back wall. And once that's the case, then you simply rotate the ball. And it's usually about a 360-degree rotation. And you can go through the images here, 1, 2, 3, 4, and you can see as we rotate, the appendage is essentially disappearing and the ostium is coming onto the shaft of the device. So we do this under TE, and we don't puff while we're doing it because the contrast, interferes with the imaging on TE. But you can pause and do puffs along the way. So I want to just show you the sequence. I showed you on TE what that looks like. This is what it looks like on fluoro. We have the initial position on the left, and then you can see on the right upper, that's an early wrap. It's starting to close, but there's still contrast entering the appendage. And on the lower right, it's fully closed now. We're injecting, and there's just atrial wall there, and there's no contrast entering the appendage. So the appendage at this point is closed. Once it's closed, then it's just a matter of locking it in a closed position, and that's where the lock comes in. So the lock is being exposed here, and it's keyed to the ball. They cannot rotate independent of each other, and it's essentially, there's just a small screw mechanism where the lock and the ball come together. So you can see here the distance between the lock and the ball initially on the left, and then as you advance the lock, it closes and the tissue is compressed between the ball and the lock. So on the final appearance on the right, you see there's a space between the lock and the ball. That's the atrial wall that's locked in. And then we do an angiogram, and you usually get this very flush kind of appearance. So we'll check again on TE. We have what we call the SEAL criteria. We look for ball symmetry. We look for echo closure, angiographic closure, and lock appearance. So that's our pass criteria. We call it the SEAL criteria. And if we pass that, then we can actually deploy the device, and this is the final appearance with the closed appendage on fluoroscopy. Do an angiogram. There's a flush occlusion of the appendage on the atrial wall, nothing sticking out. And then on the bottom, you see the TE images of the device. And here, this is a 3D with the mitral valve at the bottom. So in conclusion, laminar is a relatively new procedure, and it excludes appendage by rotation. There's minimal residual surface area. The EFS trial is completed, and the pivotal trial in the US is currently underway. There are 4 sizes planned, and it's a 1-to-1 randomization of laminar versus commercially approved or qualified Watchman or amulet. Could be either, and it'll be a 1-to-1 comparison of the outcomes. So that's my presentation. Thank you so much.
Any questions from the audience, the panel? There's a question up there. Yeah.
Yes, hi. Right. So for both, we're dual antiplatelet therapy for 30 days. Yeah. So the anticoagulation for the commercial devices is per IFU. So for Watchman, it could be also dual antiplatelet therapy. They're approved for that, or amulet as well. So it's the same for both. The duration is slightly shorter with the laminar device, but it's essentially 45 versus 30 days. Yeah.
So Jason, I've got a question. It seems that from at least the case you showed, the device animation, that complex morphology kind of at the distal lobe will be less of an issue with this, because it doesn't really matter what's happening right in the distal bag, to use your analogy. So I think that appears to be helpful. The fact that you're closing at the ostium, one hopes that peri-device leak is less, and then the residual footprint seems very little, so hopefully DRT is less. Are those kind of the 3 advantages of this compared to what we have available at the moment? Yeah, I mean, I think our distal anatomy first. I mean, it doesn't matter that much either for Watchman or amulet, because ultimately those devices are deployed proximally, although you may require initially some more depth to unsheath the device. So in terms of the outcomes, I mean, DRT that has not been an issue because there's just so little surface area. Seal, I think we have had some leaks, and we're still learning the best way to optimize that. The leaks with this are
significantly different, I think, than other devices because we wrap the appendage. There's not really a lot of residual appendage volume. So we actually have devised some new descriptions that have, we're working with the core lab, where we describe not a leak, but it's more like a fold or like a little pocket. Because if you look at the way the tissue wraps, there could be some little folds or something that look like a leak, but they actually don't communicate with the appendage. So there'll be some interesting findings there. Ultimately we'll see what the data show in the pivotal trial.
Jason, just two questions. One, the trial design. So is it a non-inferiority design with a primary endpoint at 1 year suggests for stroke and bleeding?
Right, it's a clinical endpoint, primary endpoint, stroke or systemic embolism. And then there's a secondary endpoint which involves
bleeding.
And the primary endpoint also involves safety. And then the secondary is, residual leak, DRT, those types of things. But yes, it's non-inferiority.
And the other question is, we had the Lariat, which sort of had a similar, not necessarily similar in the sense it was partly coming in from the outside, but the idea was that there were leaks with the Lariat, but the leaks with the Lariat were in fact more likely to produce DRT because of the fact that they were pinhole and they were very, very high velocity jets that were forming in those segments. And
I think when people see this, they kind of like, oh, that's kind of like Lariat, but it's actually nothing like Lariat. It's very, very different. First of all, it's far less invasive. You're not doing a dry pericardial tap, and with Lariat, you were really giving a tourniquet, and the whole appendage would basically necrose and die over the next 3 to 5 days, and so those patients had horrible chest pain and everything. We're rotating the appendage. It's a much gentler closure. But importantly, with Lariat, you left behind the entire volume of the appendage there. It was like a gunny sack. You close the sack, but the entire bag is there full of thrombus. So this is much different. We're wrapping it, and it really gets, I think, the residual volume is very little. So I think that's different as well.
Jason, I have a quick question.
Yes.
Quick question.
Yes.
Is there any type of anatomy that you would consider to be non-suitable for this? So, too shallow perhaps, although it sounds like the depth is the minimal depth is 7 or 8, but is there anything,
about 9 millimeters.
appendage comes in all sorts of, shapes and sizes, but is there something that you found that you shouldn't be using with this?
I would say our main limitation at this point is we don't have like a super large ball, so we're not treating really large appendages at this point. But in the EFS, we had numerous cases that were, commercial device failures that were enrolled successfully. But there certainly be cases probably that, we can't treat that could be treated with Watchman or Amulet. So as you know, the appendage is always surprising. When you look at it on imaging and even with FEOPS, I mean, you make a plan and then sometimes you get in there and it doesn't sit the way you thought it would sit, and it's always a little bit of surprise. So there will always be those kinds of cases, but in general, we were successful with a whole lot of anatomies because of the mechanism. But for very big ones, I mean, I think Watchman still, I mean, they have a 40 millimeter device. We're not treating 35 millimeter appendages yet at this point.
But so it sounds like mostly size rather than morphology of the actual appendage.
I would say so.
Okay, that's very encouraging. Great.
No, thanks,
yes. So in our EFS data were presented at TCT. So we look at leaks, less than 3 millimeters and greater than 5 millimeters. So I think in the initial EFS series, we had a few less than 3, and I mean we had 1 over 5. So there are a few leaks, but with those leaks, we've not seen any associated DRT or clinical events. So I do think the leaks that we see are going to be different, but you're going to need a lot of patients to prove that. But they're not mechanistically the same as other devices. There were 50 patients in EFS. Yeah.
So maybe you could refer them to as gutters. I mean, that's essentially what we do with the Watchman and Amulet devices. Those blind pouches, we refer them as gutters.
Yeah.
Yeah. What's the possibility to distort the mitral annulus?
We're not applying that much, so the circumflex is there, obviously, and so we have not seen any circumflex distortion in the first 50 EFS cases that we did. We did a left circumflex angiogram in all those patients, and no patient had any circumflex injury or distortion. So that's number one. And then I think to distort the mitral annulus would require, even more. So we didn't see any mitral valve issue. We don't have anchors, we don't have anything that sticks out on the device, so we've not had any late effusions or anything like that. I think that may be an advantage as well, that there's nothing sticking out, so we don't have any issues with interaction with the PA or any other pulmonary vein or any other adjacent structures.
So the reason for anticoagulation, I presume, is the lock that is exposed to the left atrium.
Yeah, that's the only thing that's exposed. So it's like it's almost like a bare metal stent. It's very low profile. Yeah.
All right. I think if there are no more questions,
we're
running a little behind.
Oh, okay.
So call it a wrap, unless there a burning question for somebody else in the audience. One last question. Yeah,
John.
Go for it.
Yeah, we included both paroxysmal, persistent, and permanent. So it was a smattering. Some of our electrophysiologists, most of their patients have been ablated already, but we didn't see any significant change in rhythm status with the device. Yeah.
All right.
Okay.
Thanks
Thank you.
again, and have a great rest of the conference.